diabetes becomes number one. So
Really?
it supersedes ischemic heart disease and stroke is at the top of the list.
Dr. Christopher Murray is a health economist, global health researcher, and professor and chair of health metrics sciences at the University of Washington.
We've seen this big shift from the infectious diseases, the maternal causes, the nutritional deficiencies, towards the non-communicable diseases. Right. Really profound.
He is also a founder of the Global Burden of Disease Framework, a scientific approach to quantifying the magnitude of diseases, injuries, and risk factors across 204 countries and territories.
We have 19,000 collaborators in 167 countries. Intentionally, like we target countries that are not active to find people because we want it to be truly global.
He sat down with me to discuss the GBD's backstory and headline findings, including global health successes, current challenges, and emerging threats. Welcome to Stanford Department of Medicine's Inside Look at the Future of Medicine. Chris, welcome to Stanford.
Great to be here.
It's we just heard a wonderful grand round. You spoke to a packed room full of people, standing room only. And so now we have an opportunity to chat a little bit about the global burden of disease, about your career. But I wanted to start at the beginning. I love it when we have guests here and we have a chance to chat a little bit about how you ended up where you are. And so my question is this: did you ever, as a kid, imagine you were going to be running this, this enormously impactful study from the position you're in? And how did you end up with so many degrees and qualifications?
Boy, simple questions, right? My parents did medical work in Africa. So my dad was a cardiologist. We're from New Zealand, moved to the U.S. for work. He did at Mayo Clinic and then University of Minnesota. And then at some point in the 70s, a lot of turmoil. My brother's a little bit older, said, what are you doing for society? You're just, this. And so to respond to that, he took a sabbatical. And we bought a couple of Land Rovers at Solihull in England.
Wow.
Arranged through our church to find a hospital built in eastern Niger that had never started.
Wow.
And we drove out, and my dad used the kids and the family as the labor in the hospital. So at 10, I was my dad's pharmacist and surgical assistant.
So you drove from England?
We drove from England. We went through Spain, Morocco, across Algeria, across the Sahara, and got to this place.
Wow.
And then we ran this hospital.
And you were 10 years old?
I was 10. And then my parents were hooked, and they kept doing that for the rest of their careers.
Right. But even prior to 10, you spent some years in New Zealand and then some time in Minnesota?
Yeah, sometime in New Zealand. My dad had done one prior sabbatical in Oxford, so I did a little bit of schooling in Oxford as well.
Yeah, we'll come back to that.
So, we were sort of already a little bit of a globalist family.
Yeah, so you were working in a hospital in Africa at 10 years old helping your dad.
Yeah, and then they did work in the Comoro Islands, in the Ogaden of Ethiopia. Yeah. A lot of years in the Rift Valley in Kenya, and then their final stint was in Malawi, by which time I was off, doing school and university. So that set me on
a path. Did you ever consider doing anything else, or was it always going to be medicine from an early age?
I went through a crisis of what should I do with myself. Like when I was a senior at Harvard, and the choice was sort of something in global health because I wanted to have more population impact than I'd seen my parents having. Yeah. But the other one was I really love the outdoors and animals, and so I thought about being a park ranger in Africa.
Wow.
So
really?
That was the big choice.
Okay. Well, being a doctor to humans or on population scale or doctor to animals on a slightly smaller scale, those two things align. But in the end, you chose humans.
I chose humans. Yeah. I got a fellowship to go to Oxford and
a Rhodes scholarship.
I got a Rhodes scholarship, and that was great because then I found the right person to work with who was not at Oxford. He was at the London School of Economics, Brian Abel-Smith. Yeah. So I went down I want to have more impact, so I need to learn about money and how health systems work. Yeah, I did health economics, and then I went back to medicine at Harvard after that.
So even before you finished your medical degree, you'd already taken a kind of side turn towards economics.
I had, yes. And I, partly this sort of quest, which I'm still on, how do you like make large scale change?
Yeah.
And got stuck along the way. Well, we don't know a lot about what people's problems are.
Right.
And then, we really should try to fill in the gaps, know more, figure out what works and how you can have impact. And that's the journey.
Well, I was just talking, stimulated by your talk, actually, just talking to one of my colleagues about this idea that we're interested certainly here at Stanford in having a big impact on the world and on the world of medicine and the world of health. But the starting point for that is understanding what are the big problems. And there really is no better resource, and obviously before you built it, there wasn't really a resource to understand what are the biggest problems in health today across the world. As we'll come to talk about, you're also projecting forward to the future to help us think about what the big problems might be for humanity going forward. But in your case, it sounds like you saw the need, and you were driven by the desire to make change, and realized that you didn't know where to kind of fire that cannon. So that's what led you to start to quantify disease. Is that what it was?
That's sort of why that question about what are the big problems was so preeminent in my mind.
Yeah.
And then I just got this great opportunity, which was when I came back from Oxford and was in med school. I was also a fellow at the Harvard School of Public Health in Lincoln Chen's department at the time. And somehow, I don't even remember the sequence of events, but I started doing some work with the World Bank. Mm-hmm. Mm-hmm. And when they came round to deciding to do their annual policy assessment on health for the first time, fortunately for me, the person running that team, Dean Jameson, asked me if I could help and then with Alan Lopez at WHO, answer the question. Mm-hmm. And turned out that was a non-trivial undertaking.
Right.
But we really did back of the envelope pretty simplistic stuff with what we had at hand in 1991, 92. But that just got some momentum and just sort of kept going. And then I went off to WHO with Gro Harlem Brundtland to do it there.
Right.
And then she stopped, didn't do a second term as Director General, and that's where I sort of moved back to academia to do it.
Yeah, interesting. Jump us forward now then to the latest update and where we are, and we can sort of fill in the parts along the way. But the impact of your study, it's hard to even call it a study. it's much more than that. But give us some statistics to give the people listening here just a sense of the impact and the size, shape, and impact of the global burden of disease.
Because it's just kept going and growing, we have a ton of people involved. Mm-hmm. So we have 19,000 collaborators.
19,000?
19,000 in 167 countries. Okay. Intentionally, like we target countries that are not active to find people because we want it to be truly global.
Right.
But because of that, then lots of academic output, 5,000 plus papers from the GBD. But probably more importantly, just tons of use by funders and governments as the sort of first stop to sort of understand how big is disease X or problem Y.
Yeah.
And
you talk about 5,000 plus academic papers. First of all, those were mostly in pretty big, high impact journals.
A lot of them are in good journals.
Yeah. But also you showed a slide at the talk just now where I think you mentioned you'd used some agentic AI systems. We'll also come back to those to try and sort of measure the impact on policy. Tell us a bit more about that.
Yeah, I mean, because we've always wondered, like who's, and we get these anecdotes. The president of Botswana used the alcohol numbers to put through legislation on alcohol type story. And we, replicated. But, we were data people, so we wanted to have a way to see if we could track this a little better. Nobody wanted to pay for it, but now with agents, we just sent them on their merry way and said, go find all the documents on government websites that make use of the GBD. Yep. And then, once they collected them all, we said, read all these documents, there were like 4,000 of them, and make a typology of uses, both by topic, but also by like what's the purpose they're using? Is it
Yeah.
for resource allocation? Is it for priority setting?
Right.
Is it just general strategy development?
Yeah.
And it did a nice job of that. So what we realized is there's a lot of uses. Some of them we never even thought about. Like for example, now a hot topic is using the forecasts to predict how many specialists in different clinical specialties
Yeah.
we should train.
Okay.
Because you want to train not for today.
Right.
You want
Right.
to train for 20 years from
Yes,
now because they have a
exactly.
40-year career, let's
Right.
say. And so, we didn't come up with this use case, but people find clever ways to use data and forecasts.
Yeah, and I think that the testament to you sharing so broadly, not just through publications, but also allowing the data to be available and for collaborators to work on it.
Yeah, and for anybody to go to the website, GBD Compare and look and explore, right?
Yeah. So the thing you must get asked all the time, I'm sure, at parties and everywhere else is, what are the headline findings? I mean, what are the things that surprised you? What are the things that have changed? And you had some nice slides summarizing them. So I know that you're used to being, having to find a succinct way of summarizing. I mean, I would, half the room here were taking photos because the ones who don't immediately know which paper to go to see those, that's not information that many of us carry around in our heads, and yet probably it should be. So.
Yeah, we do, because there's so many numbers and so much detail, it's sometimes easy to, even for us who are intimately involved, to just get lost.
Yeah.
So it takes a bit of doing to say, okay, let's boil this down to some high-level messages, right? And so we try.
Yeah.
And I'm sure somebody coming from, this is my favorite problem, will say, well, you left my problem.
Yeah.
But
Right.
with that caveat in mind,
Yeah.
at the macro level, the world, because of population aging, because of progress on infectious diseases in kids particularly, because of ART for HIV, we've seen this big shift from the infectious diseases, the maternal causes, the nutritional deficiencies, towards the non-communicable diseases.
Right.
Really profound. And even in the low-income world a little bit, but very dramatic changes in a place like Indonesia or Brazil or India even now, where the pendulum has really swung over to heart disease, chronic respiratory disease, and then NCDs more broadly, mental health, the musculoskeletal disorders, those also making, being a big factor.
And I think for some of the people listening, even that terminology might not be familiar to them, but we define non-communicable disease almost like the exclusion. It's the inverse of communicable diseases, which were infectious diseases, because those were the biggest killers when you started this, right?
Yeah, and in fact, in this sort of it's a weird label for sure.
Yeah.
And the non-communicable diseases has just become a thing globally, right? There's UN high-level summits on NCDs.
Right.
But yes, it's the heart disease, cancer, diabetes, chronic kidney disease
chronic
stuff.
degenerative diseases that people will be very familiar with. Right.
So that's one really, really macro view.
Yeah.
And then if you drill down, a step, we've had this incredible progress in reducing death under age 5.
Yeah.
Less progress on deaths in adolescents, but the rates are much lower.
Okay.
But still, tons of progress, but still huge disparities. So it's like still 10 to 1 on the risk of dying under age 20 from the low-income world to the high-income world, despite all this progress we've had.
But the curves are parallel each other, so there's improvements in both places.
There's improvements everywhere, but the improvements are bigger in the low-income world.
I see.
And part of that has been the success up to now of the money that's been spent by the high-income world on programs in the developing world, right? Those have actually been really successful.
Yeah.
Diarrheas, pneumonia, malaria, super impactful. HIV, another huge impact. So, that's one high-level message. So success, but huge disparities still. Secondly, we talked about the big shift to NCDs, but it's really strong in the sort of Asian countries in Latin America.
Yeah.
Third is the rise of mental health as we're seeing in the data. There's still a lot of debate. We're now seeing, well-conducted surveys using the same methodology that show a big increase in anxiety and depression.
Yeah.
Why is a debate.
Yeah, not just around COVID, though.
No,
right?
not just the COVID.
Because that seemed clear at the time.
Yeah.
I mean, that was widely reported.
No, it started well before, probably a decade before.
Then, right.
And it's trending up, big spike during COVID, but still going up.
Yep.
And now we get into really heated debates is the why. Is it Jonathan hates social media?
Right.
Is it, devices? Is it despair about, employment and, the future? Is it climate change despair?
Yeah.
Long list.
Yeah.
And when you talk to the mental health epidemiologists, they do not agree with each other, right? So there isn't a consensus in that field.
Right.
On the why, there's
Yeah.
now a consensus that it's getting worse.
It is
right?
getting worse. Right.
So that's a really interesting phenomenon going on. And then, of course, the obesity epidemic is getting worse everywhere,
Yeah.
not just in the U.S. In
Right.
fact, the worst in the world is sort of Mexico, the Pacific Islands,
Right.
the Middle East are the places where it's the worst.
Yeah.
But it's just going up everywhere.
But you alluded to this just briefly in your talk. I mean, there was a fairly widely distributed graph of America's obesity rate that had kind of leveled off a little bit. It gained quite a lot of traction last year. I can't actually remember its origin. You kind of alluded to it and said that maybe there had been some walking back of that.
Well, remember each round, what that was, I think it got picked up in the Financial Times,
Yeah,
actually. It got
yeah.
spread everywhere because
Yeah.
of that. But what that is that each round of NHANES in this country is a pretty small sample, and it's sampling a very small number of communities because they have to drive the big vans around
Right,
to
yeah.
do the measurements. Meaning that the uncertainty intervals on the measurements of obesity are like plus 2%, minus 2%, something in that range.
Right.
And so there isn't actually a statistically meaningful flattening yet.
Yeah.
And when you look at the self-reported data,
Yeah.
which obviously not as good, but still
Yeah.
tells you about trends, it's not flattening yet.
Yeah. Right.
So that's why I think we're sort of skeptical. Now, GLP-1s
Right.
should.
I mean, there
It
are
has to.
$50 billion worth of spending on those drugs. I think almost everyone can point to not just one, but probably multiple people they know who have changed their appearance dramatically.
They are fabulously impactful, but
Seems like at some point that will
some point we
likely
should see
affect
it,
the
right?
numbers.
And especially once the the fully oral ones are being marketed,
which is just coming right now, basically. Yeah.
And then, so I'm pretty hopeful that we'll see some breaks on that.
Yeah. And this might be the beginning of a signal, but that particular signal
that particular one was oversold.
Yeah, got it. Yeah. So these are these big categories, and you've mentioned how they've changed over time. You mentioned the disparities. What's give us a sense of the size of them at the moment? You have this great graphic. You talked about the rectangular pie chart.
Yeah, the tree map.
What are the big health signals there, or disease signals there that we can explain to the people listening?
Well, the ones that have always been there, and that's why there's so many cardiologists out there, have been ischemic heart disease and stroke, right?
Yes.
And to a lesser extent, some of the other, cardiomyopathies, et cetera.
Yeah.
But now we see, really diabetes and chronic kidney disease on the rise at the global level. Those are becoming very prominent in terms of within that bucket of the non-communicable diseases.
Right.
Lots of mental health and depression, anxiety. We're seeing, the bucket of back pain, neck pain, all the causes of those that are, unfortunately, we don't have a lot to offer for them, and they go up with age.
Right.
And so as the world ages, there's just more and more and more of those.
Yeah.
We have, dementia going up in terms of numbers, not the rates, but the numbers of people.
Yeah.
And then on the injury side, there's an interesting one that we didn't talk about too much in that presentation, but falls are on the rise. And there's all sorts of theories as to why, more elderly people,
more frailty,
living on their own, all sorts of things that might be accounting for this pretty substantial effect of falls.
Yeah.
Some age groups, linked to the mental health, suicides are up in some of the adolescent age groups.
Yeah.
And then, of course, we have the ongoing malaria, TB, pneumonia, diarrhea, neonatal causes.
Yeah. I noticed you showed this contrast between, I think, the early 1990s data and the 2023 data. And of course, there's changes you've discussed in infectious diseases, but it's hard to not notice measles in the middle, which at this stage is smaller, but we're all aware of the data that it's...
Well, measles was a top 10 cause in the world in 1990.
Yeah.
It's now like 70th or 66th.
Yeah.
So, we've had, because of vaccination,
Yeah.
huge impacts on measles. Now, of course, we're in a period where vaccination rates have dropped in a number of geographies. Fortunately, not so much in low resource settings yet.
Yeah.
But you have to worry, right?
Yeah.
Because of the funding for programs like the Global Alliance for Vaccines, or Gavi.
Yeah. I mean, you talked about the numbers of people who've used your data. I imagine, as the encyclopedia essentially of health now, and with some projections in the future, you must get a lot of interesting incoming questions. I'm imagining from legislators, but also I assume from pharmaceutical companies and others who are interested in where they should apply their R&D. Tell us a little bit about that side, or tell us some interesting stories from that part of your life.
Yeah, I mean, the pharmaceutical industry is interesting, right? Because they really are avid users of data. They're very much a data-driven industry, right? Which is good, right?
That's what we want.
So it's both a strategic use, like where should we put our capital in terms of new products,
right.
and new markets for existing. Should we? Takeda has a dengue vaccine. Who should be the next place they target for licensure? That sort of type question. So we have a lot of engagement with or questions that come from pharmaceutical industry that they have their own in-house epi expertise as well. So they look at our stuff and then they'll try to verify that their own in-house analyses agree, because they make decisions that are quite costly.
Yeah, right. $billion investments in drug development.
So that's one group. We see actually quite a bit of use by some people, like in the healthcare delivery side of things, not just pharmaceuticals. They're interested in, are there conditions for the groups that they're looking at that they haven't targeted yet?
Yeah, right.
And then there was a period, still some out there, where people are interested in plugging in the epi into automatic diagnostic, Bayesian diagnostic algorithms. Like you come in with a certain symptom cluster, and if you're in Rwanda, it's probably a different disease than if you're in Cleveland.
Yeah.
And so they can take what we have and feed that into.
Yeah. Insurance companies, presumably, as well?
Insurance companies, some. They're often more interested in death than in the cause of death or the disease, right?
Yeah.
There's just some exceptions to that.
Yeah.
Reinsurance people, somewhat.
Right.
We've started to do a lot of climate modeling and work by necessity, right?
Yeah.
And so then some of that starts to be interesting, like where are storms and floods and things like that.
Right.
Yeah.
Well, you'd also talked about projecting into the future. So I'd love to talk for just a minute, first of all, about the disease boxes that we were talking about in a moment and what they look like in the future. And then we'll get to some of the really big questions. So let's start with there. If you project that box, kind of your rectangular pie chart into the future, what are the significant changes for the next 10, 20, 50? You go right out to the end of the century.
We go right out with trepidation to 2100. So, the continued trend towards more NCDs, but because of obesity, a little bit in interaction with temperature, really big increases of diabetes and chronic kidney disease. So that diabetes becomes number one. So
really?
It supersedes ischemic heart disease and stroke is at the top of the list. We see, ongoing more mental disorders in the future, stubborn, communicable, the infectious disease problems in places like the Sahel, because there's so many more people in the Sahel as you go through the century because of high population growth.
Right.
Excuse me.
Yeah, you mentioned that although the frequency of some things may go down because it's outplayed by the population growth, so the absolute numbers go up.
Yeah, I mean, if you want a concrete example, take Niger, right, which it barely has changed its income per capita in 75 years. hardly different than 1950.
Yeah.
Gone from a child death rate of like 350 out of 1,000 babies dying before their fifth birthday down to about 100, maybe slightly more.
Yeah.
So huge progress in kids,
Right.
a little bit of progress in adults. Government's not particularly functional, so this is really a testament to the programs that are being funded externally and delivered. With obviously local people delivering the interventions, but they have not really changed fertility very much. So still, most women have 6 kids. You put that into a place that's just a thin strip of Niger is habitable because the rest is the Sahara and there's desertification. And you run that into the future, you get the population of Niger just going up by many multiples, right? Yeah. And so the population growth is in the places where people will likely stay quite poor, likely have the biggest effects of climate change. So you get this sort of concentration of lots of health problems in the Sahel belt all the way across. Yeah. And that's why, despite general progress, we're still going to have malaria and pneumonia and diarrhea and neonatal disorders, even as we go out into the later in the century.
And you project later in the century, we're still thinking of those as significant.
Which surprised me, right? Yeah. I thought, we've made so much progress in 75 years that the people who've been left behind somewhat, even though they've had quite a lot of progress, would just sort of grow out of it, which is why I keep coming back to what can we as the world do to help accelerate economic growth in these places? Because without that, it's hard to see, this story of this gap with the Sahel and the rest of the world not being a really big issue.
Yeah, amazing. There are very few people who I think are really thinking in concrete terms with data this far out. I mean, we're usually talking 5 or 10 years.
Yeah. And maybe we shouldn't be.
Yeah, well, that's maybe what we'll come to now, because this one of the interesting places that this study and your career, your work has drawn you is into very large questions, and particularly the focus of the Lancet Commission includes everything up to and including human extinction. So tell us a little about that, how it came about, and what you have been concluding recently.
So I guess 3 and a bit years ago, I started talking to Richard Horton, the editor of The Lancet, and to Natalia Kanem, the head of the UN Fund for Population Activities, about the fact that we were still in the pandemic, but coming out. Yeah. There was quite a lot about climate. Yeah. But were we sure that, and actually Ukraine had just been invaded, right? Yeah. Were we sure that was it? Were those the 3 things we should worry about, and we can not worry about lots of other things? And we had the idea that maybe we should have a data-driven, evidence-driven approach to thinking about what are the big problems. Yeah. And then we had to have we had an interesting group come together as commissioners, and then we had some really interesting, almost philosophical debates, like, is it reasonable to look out to 2100? And then the climate people will come and say, of course, because the carbon we put out in the atmosphere is going to have effects for the next 200-300 years. So of course you have to look out far, because that's where the harm is. Right. And then other things, once you take a longer term perspective, you also start to change your view on some other threats, right? Yeah. So we said, yes, okay, we'll go out to 2100. It's longer than most people are comfortable, but the climate folks have already made that leap for us. Yeah. For good reason. And then we started digging into what could be the set of threats and trying to find a way to look in a very even-handed way, and both the ones that come straight out of the burden of disease type assessment, but all the other ones that people are worried about, obviously AI, nuclear winter, and on down the list, and including, even in the discussion we just had, somebody came up to me afterwards and said, you should have put in mirror life. But,
right. Well, let's unpack that for a moment, because certainly on this podcast we've talked quite a lot about AI. Over the last few months, things have changed dramatically in that sphere. In fact, the first time we met was probably a year ago, I think, and I remember you put AI on the list, and at the time I was still a bit like, well, that makes sense, but I was still a little skeptical. I've changed my mind completely, and the last few months have changed most people's minds. I mean, I think if you're not paying attention at this moment, or if if you're not a little scared, you're probably not paying attention. And so it's completely reasonable. But yeah, talk us through the process that led you to, and maybe explain what mirror life is for the for the audience.
Mirror life is this idea that all of evolution has been producing left. Sorry,
Yeah,
it's been organic chemistry is a long time ago. Left-handed, molecules, and if you make right-handed ones, the immune system and others would have no defense.
And now we can, with synthetic biology, make whatever molecules we want.
So there is the possibility of really terrible things being made.
Yeah.
But how do we come up with it? Well, part of it was people putting on the table from the data.
Yeah.
Putting things like AI, because it was already out there that people were worried. You had philosophers at Oxford like Toby Ord writing about the potential catastrophic risk. And there's this group, strong here, I think in the Bay Area, of effective altruists, the EA community who think about thousands, if not millions of years into the future and say, what we should really be worried about is, getting off the planet and this sort of thing. Yeah. So we were trying to listen to that, but not get caught up too much in the overly Star Wars type stuff. Right. But once you start down that road, then you put on the table things like AI. And once you look at it, particularly AI being used to design highly transmissible lethal pathogens, because a bioweapon doesn't have to survive natural evolution. Because the evolutionary argument is, if it's too lethal, it won't continue to spread. But the terrorist or the person trying to do harm doesn't care.
Yeah.
Just wipe everybody out in the first go, right? So that becomes and I think all the people that I talk to in close to the foundation labs are super worried about the bioweapons part. For legitimate reasons. And then there's other, there's loss of control, there's systemic, manipulation by AI of systems that can have really quite large, just think hospitals, right?
And there's a big debate. I mean, it's literally in the news this week around the Defense Department or the Department of War
autonomous killbots.
Changing their contracts, and whether a line in the sand was drawn by Anthropic in particular, and whether that line was different from other of the frontier model companies. But there is no doubt that each of those companies, and I think in particular Anthropic, actually has a section that is concerned and focused on the autonomous element of the AI and the harm it can do. And they have regular tests that they run at Anthropic specifically where they test those, and they test each new model in that way. And those are the people who are worried. So
yes, it seems very legitimate to me to be worried. And from our point of view, is there a risk? Answer is obviously yes. Does it matter if it's 1% or 5% or 10% extinction risk? Probably not. It just that there is a real catastrophic risk there, so we should take it quite seriously.
And I mean, in one of my AI talks, I put up the slide of the P doom, the probability of doom that is held by a number of the prominent AI researchers and CEOs and others. But first of all, in almost no cases it's zero, which is the point that you're making. For some, it's low, in the low percent range, but for many, it's 10 to 20%.
It's a big risk.
Which is that's a big number from people who truly understand how this technology works.
And there's an interesting divide, right? When people between the people who work in those companies or experts, always higher than this class of people called super forecasters, which these are people that have generally, nobody knows why, are good at predicting things.
The future. Yeah.
And they
Aren't you one of those? Aren't you a super forecaster?
No, I just set up the systems.
That'll allow the models to predict.
But I think it would be a grave error to dismiss it. And when we started 3 years ago, because we already had it on our list from the beginning of discussion, there was a lot of giggling. Yeah. There is the Terminator really put us back, right?
I know. But the more you think, the more you worry that our fiction writers from the past, perhaps were quite prescient in what might be possible. And I agree. When I first made the slide of Jeff Hinton suggesting that we really should be careful about human extinction, it was partly as a joke. I mean,
Yeah.
you know, and then I contrasted it with multiple other of the Nobel Prize winners for AI who were countered to that. But the reality is today that it's not really a joke anymore.
No.
And there's examples of real harm and real harm done at scale. And to your point, I think you don't need to understand much of biology or AI to understand that the possibility of biological warfare is real. So the question is, this is really beyond your realm, but what do we do about all of that? I mean, this is a question for our...
Well, you know, on the bioweapons front, there are, you know, proposed strategies, more careful regulation of who can buy the right ingredients, the nucleotides, et cetera. And, you know, monitoring of purchases of anything that could be a precursor. So there's a package of sort of monitoring regulatory stuff that people talk about. I don't know. It's one of those things you would only know that they probably won't tell you if the government detects this. Right?
Right.
The one that's a little systemic risk, you know, you can try to think of ways to make hospitals and other critical systems more resilient.
Yeah.
The one that's really hard is the alignment one, because the big labs are trying. But, of course, the argument that they all make is that the competition with China is such that nobody's really going to slow down.
Yeah, it really is an arms race at this point.
Yeah, and so that's really worrisome.
Yeah.
Right.
No, an interesting. We obviously can't end on that note.
No,
because we have to think about. There's a lot of positives in, of course, from your study over the years. I mean, I think the fact it exists is a huge positive. I mean, it's just congratulations. I mean, it's an amazing achievement. But I think while a lot of the nuance is only available when you dive a bit deeper, as we have in the last few minutes. The overall trends, some of them are incredibly popular when you talk. Incredibly positive when you talk about the reduction in mortality and age under 5. There is progress, right? I mean,
tons of progress, and you saw the graph of life expectancy that despite climate, despite these risks that are out there, our best prediction for the future, or most likely, not if things continue as the trajectory we're on, is things will continue to get better, right? So we are fundamentally sort of saying, we think the world will get better. We can do a better job. We can try to address some of these threats in a more effective way. But on balance, the future is probably going to be better than the past, right? Yeah. Now, the world's full of half full, half empty type people. Yeah. But we're basically saying there isn't. The other one that's really positive is that. Yeah. Climate's a serious risk, but it's not a catastrophic risk this century.
Right.
Okay. And so, some young people, like at school, they're really anxious about the world getting too hot for humans to survive. There won't be enough food. Right. None of that seems possible this century, right? The people, lots of bad things, but it is less extreme than some people who are very anxious about climate may think. So there's some positive messages there.
Yeah.
And, we shouldn't go to sleep on that watch.
No complacency there.
No complacency, but it's not shouldn't be a source of existential angst for kids and others.
Yeah. Well, Chris, thanks for the amazing work you've done over decades in building this unique resource really for the planet. And thanks so much. This was your first time to Stanford, right?
First time to the med school at Stanford.
Yes. Okay. Well, we'll have to make sure we have you back sooner rather than later. Thanks so much for joining us.
Thanks, Euan. That was great.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.